Hi guys, so this is Holly Frost. I am a pediatrician and senior research scientist at Denver Health and the University of Colorado. And today I'm going to talk with you about OASIS, which is Outpatient Automated Stewardship Information System. This talk is really designed for antibiotic stewards, healthcare administrators, clinicians, and pharmacists. If you're looking for a more technical talk, we have one that's published that is more for data analysts and health informaticists as well. So why use audit and feedback? And I think if you're listening to this talk, you probably realize that audit and feedback is one of the most effective tools that we have to reduce unnecessary antibiotic prescribing and is one of the CDC core elements of outpatient antibiotic stewardship. Unfortunately, we know that of the stewardship tools we use, it can also be one of the most resource-intensive tools. And unfortunately, we know that sustainability can really be a challenge with audit and feedback. So this was a study that was done by Jeff Gerber and his team at CHOP, and you can see they implemented an intervention that included audit and feedback and saw a tremendous reduction in unnecessary prescribing. And then upon stopping audit and feedback, you can see prescribing rates went back to normal. And so we know that we can't just implement the audit and feedback systems for a period of time, but we really need to think about how we sustain feedback to providers over a long period of time. As a stewardship community, we've really had a scalability problem. So we can design really effective programs that work in research studies or in select clinical settings or healthcare systems, but unfortunately we don't disseminate those very well, and they're not necessarily translatable to all kinds of different settings. And so one of the primary goals of our team is really to think about how do we create effective programs that are translatable to a broad variety of settings and that are easy to implement so that we can scale them across the country. There are a few major challenges we've uncovered with audit and feedback. This was a project that we did with the American Academy of Pediatrics and CDC. It included 6 practices in Virginia and 8 in Colorado. And the goal was really to improve prescribing for pharyngitis and for acute otitis media. All of these practices were part of healthcare systems, but were not part of the same healthcare system. They had electronic health records, and we used audit and feedback to improve prescribing. And unfortunately, what we found is that after the intervention, there was no practice that continued audit and feedback in the sustainability period. And the primary barriers that we identified were that it was incredibly time-consuming for these practices to create audit and feedback reports and distributing them. So the average time spent was about 4 to 20 hours per month. Many systems found it was really difficult to access data, especially because they'd have to repeatedly ask for data pulls and then compile the feedback reports on a monthly or quarterly basis. They weren't sure if clinicians actually read the reports, so they weren't sure how if there was any utility to them. And then many of these practices have looked at using EHR platforms to provide feedback, but found that they were really expensive and also had limited flexibility, not just in terms of the metrics that they were looking at, but also in terms of the output format. In a parallel project that was done by Tim Jenkins at Denver Health, we provided feedback to people on their antibiotic prescribing for respiratory measures. And essentially, providers were emailed a link to a Tableau dashboard with the idea that they would click on the link and then they could see their data on the dashboard. And we found that with this, less than 2% of people actually clicked on the link to go to the dashboard, and found that essentially it was inconvenient for clinicians. So they didn't want to have to click to actually go to the dashboard. If they were not on our intraweb, they couldn't see it, so they couldn't just click on it from their phone. Most clinicians thought that they were excellent prescribers, so they didn't think they needed to look at the data. And clinicians felt like it was a little big brotherish, and so they really wanted the reports to be helpful and not feel like they were punitive. This was a project that was done by Pew, and they similarly found that clinicians in general think that they're good prescribers and that they tend to be very skeptical about the accuracy of feedback. But really importantly, they found that they've trusted their own healthcare system to provide feedback more so than an external entity. And so I think this is really important in understanding that you probably have the best opportunity to provide feedback to your clinicians, and they're much more likely to trust you than if it's coming from someone else. So what does OASIS do? Well, it really stems from this idea that nearly all electronic health records use a centralized data warehouse that stores data in the same way from each organization. So when we look at inpatient data, Epic, Cerner, and Meditech make up most of the market share. And on the ambulatory setting, it's Epic, Allscripts, and ClinicalWorks. And so if we develop tools that can work across these EHRs, even if we just touch the 3 major EHRs, it would benefit most inpatient systems and about 40% of ambulatory systems. OASIS is a method, so it's not a software package. It essentially uses statistical software. We now use R instead of SAS. The statistical software abstracts data from the electronic health record data warehouse and then analyzes the data in the statistical software, creates the reports and graphs. You can automatically email out to clinicians, and you can automate this so that it sends out reports at predefined intervals for as long as you want it to go out. And so everything is done in the statistical software, not in the electronic health record. We're developing OASIS metrics for our OASIS programs for 4 different metrics. The first is first-line antibiotic treatment for acute otitis media for pediatric patients. The second is duration of therapy for acute otitis media for kids that are 2 and older. The third is antibiotic prescribing for acute respiratory conditions. This uses the codes from Intermountain. Huge thanks to our colleagues at Intermountain for sharing those, and is really similar to the new HEDIS AXR measure. And the fourth is inappropriate antibiotic prescribing. So this is essentially antibiotics prescribed for tier 3 diagnoses as coded by CDC, meaning these are diagnoses that patients should never receive an antibiotic for. We are currently building these for Epic users and translating them to other EHRs. You can fully adapt this to any other metric that you want to, but these are the 4 that we're developing that are the most plug and play. There are a few advantages to using OASIS over traditional audit and feedback reporting. So the first is that it's less expensive. So R is open access and free. You can just download it. You can also use the code for free. This can be used by anyone who has R and access to the EHR data warehouse. You can use this for large data sets if you want to. So for example, Bethany Waddles has used this for the Kentucky Medicaid database. And you don't need to make any changes to your electronic health record. It's automated, so you really just have the initial startup time and cost in terms of investment, and it will go for as long as you want it to. It's very active, so you're emailing reports directly to clinicians, and you can get read receipts to see who reads it. They can read the reports directly in their email, so they don't have to click a link or go to a different platform in order to see their metrics. It's very flexible. You could use this for complex targets, research. You have broad formatting options. It's easy to change parameters. And so if you want to, you could align this with how you report other quality metrics within your organization. Essentially, anything that you can create in R, you can use to generate your audit and feedback reports. It's very collaborative. You can freely share this between organizations for rapid dissemination. And it's integrated, so you could use data from all different clinical care settings. So if you wanted, even though we developed this for outpatient, if you wanted to combine data from inpatient settings, emergency departments, and outpatient settings for something like bronchitis, you could do that if you want to. There are some limitations to this. So we feel that there's some better options for monitoring for antibiotic stewardship. So we use Tableau dashboards, but we find looking at individual audit and feedback reports is not very useful for monitoring antibiotic use across the organization. Using dashboards allows you to filter it and see things kind of at a forest level. You have to have someone with some expertise in data analytics. So someone has to be able to use R and have access to the electronic data warehouse. But it doesn't limit requests to your analytics team, because essentially they can set this up once and then not have to touch this or do anything on a recurring basis. If you are a smaller practice where you don't have someone who can use R or you don't have access to your data warehouse, there are probably some other methods that would work better for you. And so you could consider doing less frequent reports or doing something like point prevalence approaches in order to get your audit and feedback reports. And then finally, unfortunately, this is not EHR agnostic. So it is build agnostic. So if you are an Epic user from multiple different organizations, for example, and you have different Epic builds, it will generally work across those. But if you use a different EHR, it may not work across those EHRs. And we're probably not going to be able to develop them for every EHR. So if you're using a different EHR that's not very common, you may have to do some troubleshooting, and it may require more on your data analyst end. Okay, so these are some common questions that we get about OASIS. So how much does it cost? It's free. We do not provide one-on-one support for setting it up. and you do not run it off of our servers, you run it off of your own. So you will need your IT department to run it and to provide support if needed, but you can use any aspects of the code for free. What's up with the licensing agreement? Well, we do ask that if you're going to use OASIS, you sign a free licensing agreement. This is a click-through agreement in Qualtrics. You can do one per organization or one per person. Either are fine. And the goal of this licensing agreement are really three things. One, we want to assess the reach so that we can get more resources in order to expand OASIS. Two is it assures it remains free. Otherwise, somebody could download the code, copyright it, and then charge all of us to use it, which would be problematic. And the third is that it's cited correctly for dissemination so that if somebody wants to use OASIS, they know where they can access more information about it. What do I need to run OASIS? Well, you need a data analyst that can use R. This is free and open access. They need to be able to access your electronic health record data warehouse, or if you're in public health, your public health data set. And they do need to be able to do some minor troubleshooting. So if you're not using Epic or you're trying to do a more complex measure, it will require more troubleshooting. The 4 metrics that we've designed code for are meant to be plug and play, so that should reduce the amount of troubleshooting they need to do. What data sources can I use? Well, the code we developed uses Epic tables. Because these tables are proprietary, we cannot post them directly in the R code, but you can access them if you are an Epic user through the link to Epic World, which is included in the download packet. And then you just combine that with the R code. The user manual shows you how to map the data tables to other EHRs or to public health data sets. So if you are not an Epic user, you will need to either format your data tables or write your SQL code to extract it from your EHR. But we have pretty clearly outlined maps on how you can do this. Just check out the user manual. And then finally, we don't provide data sets, so you need to have access to your own data. We don't have access to big data sets or to your EHR data. You need to get that internally. Can I change the code for my project? Absolutely. So this is open access code. You can change it for whatever metric you want, and you can modify the formatting however you want. Just keep in mind that we don't provide support to do that, so you will need to use your organization's analyst to help with that. Can I share my code with others? Absolutely. We ask that you share any projects back with us. You can do this by clicking the link on the members webpage. It will ask you to provide some brief information about your project, upload your R code, and then if you need to post a link to your EHR data tables, you can do that as well. Before you share it back with us, please remove any reference to proprietary EHR data tables. Again, you can post those publicly in things like Epic World and provide a link form so other Epic users can see them, but please don't include them in the actual code. And then, of course, remove any PHI or clinician names. And then the other thing you can do too is you can include your code as a supplemental file in publication so that other people can take the project you're doing and they can replicate it at their organization. There are some helpful things that we've learned along the way. So the first is that there are a ton of different R versions, and the different R versions need different packages. So for example, for automating feedback reports or email packages, you might need to adjust this based on your R version. We have included information on how to do this based on your R version in the user manual, so make sure you check that out and that you're using one of the R versions that's compatible. We also if you find that there's new hiccups that come up, please share those back with us if you find the workarounds, and we'll add those to the user manual. Automation is fantastic if you're using R on a server. So for example, if your organization has R on a server, you can just set this up using the automation package. If you have someone who's running this based on your computer or their computer, you might want to think about actually just clicking the button and sending it out on a recurring basis rather than trying to automate it. Otherwise, your computer has to be on and logged in whenever R is programmed to send the reports, or it won't send them out. So we found, for example, that at our organization, if we're running this off of someone's computer, it's actually much simpler for us to just click the button once a month to send them out, as opposed to trying to make sure somebody's computer is on. I highly recommend that in order to track who's reading audit and feedback reports, you set up an OASIS-specific email account. So for example, at Denver Health, we have one that's oasis@dhha.org. This will allow you to track the read receipts for feedback reports without clogging up your personal email in basket. If you're running multiple OASIS projects at the same time, you can set up a separate email address for each of those projects. The reports will appear to come directly from that email account, and then you can easily consolidate those and track them, especially if you need them for things like maintenance of certification credit or CME programs. When you're thinking about developing new programs, projects are most translatable across different EHR builds, and the setup is much easier if you simplify the data you're abstracting. So rather than listing lots of inclusion or exclusion criteria, if you can keep it really simple, it's more likely that those tables are going to translate between organizations. And then finally, we've heard repeatedly from clinicians that they really want these reports to be educational, not punitive, and we've heard this across many different organizations. You can add education text, hyperlinks to different resources for them to improve prescribing directly into the R code. We encourage you to do that. We have some built into the code that we're doing for those 4 measures. And so if you're adding helpful text, again, please share that back with us so that we can share that across the stewardship community. I'm going to give you just a quick example of a project that we used OASIS for. So this was a project we did at Denver Health to reduce unnecessarily long antibiotic durations for kids 2 and older with ear infections. We defined AOM by build ICD codes and then also looked at prescription fields, excluded kids who got azithromycin and ceftriaxone, and then of course excluded duplicate encounters. You can see this was an example of a feedback report that went directly to me. So this is how it showed up in my email. It asked me to select this button so it could track that I had actually read the report. We don't use this format anymore, but this is what those reports initially looked like. And so it compared prescribing over time across our different clinics, and then also showed me my prescribing, which is not shown here, compared to others within my clinic. And the bottom graph here with the dotted line shows just some electronic health record changes that we made, and that improved guideline concordant prescribing by about 50%. When we added audit and feedback, it improved it by an additional 26 absolute percentage points. It took us about 3 hours in order to set up the OASIS code. Keep in mind that we have done OASIS quite a bit, and so we're kind of experts at doing this. About 10 minutes per month to just look at the reports, and I could do that directly from my phone. And then the results of this were fully sustained 18 months after we discontinued the program. Working with national stakeholders at CDC and Pew, we've changed the format of these reports a bit. So the reports that we're currently using look more like this. So providers will see a scatter plot of their prescribing. This is for first-line treatment for ear infections. It shows them where they are, which is the red dot, compared to others within their clinic, and then shows the other providers across the organization. And then also shows their prescribing over time so they can track it in a separate graph. We've implemented this now in different health systems with very different Epic builds using standard tables, and we've had good success. So in summary, if you're interested in using OASIS, please complete the free licensing agreement. You can log into the website and download projects, and then please share your project back by either uploading project information and code to the website so others can download it, and or adding your code that you're using for audit and feedback reports to supplements in your papers when you're publishing them. It takes a team to make this work, so huge thank you to our OASIS team. Huge thank you to Pew for helping support this work. You can follow us on Twitter, or you can also email us. Thank you.